Dear members and colleagues, first I would like to thank the organizing committee for the privilege of presenting this morning at this SAGES virtual meeting. Both me and my colleagues have nothing to disclose. As we all know, principles of laparoscopic surgery have been applied extensively to colorectal diseases for 25 years now. The equivalence of short-term and long-term results have been clearly shown for colon cancer compared with open surgery. Standard laparoscopic surgery in most centers relies on 2D image systems, which suffer from some shortcomings, including lack of depth perception and tactile feedback. Therefore, 3D systems have grown in popularity. They might help in difficult and precise tasks, including suturing and knotting, when spatial perception is a key factor. The aim of the study was to assess the effects of 3D on the short-term results of patients undergoing laparoscopic right hemicolectomy with intracorporeal anastomosis for colon cancer at a single department. We retrospectively evaluated all consecutive patients with right colon cancer undergoing laparoscopic resection between June 2005 and June 2019. For the purpose of this study, which was to evaluate the potential benefits of 3D video systems, we considered only patients with intracorporeal anastomosis, which is performed in our unit since June 2008. All the operations were performed by 2 experienced laparoscopic surgeons who had completed their learning curve in laparoscopic hemicolectomy and intracorporeal anastomosis and had confidence with laparoscopic 3D system. This is a picture of the latest 3D video system in use in our unit. Pre-operative workup and oncological management were pretty much straightforward, including all patients, colonoscopy, thorac-abdominal CT scan, multidisciplinary group discussion, and anesthesiological evaluation with ASA classification and Charlson index of comorbidity. We used the 4-trocar technique. Standard oncological principles of colon cancer resection were applied, including adequate margin resection and high ligation of the ileocolic vessels at their origin from the superior mesenteric artery and vein to allow for an adequate lymphadenectomy at the root of these vessels. The study included 107 patients, 56 were operated with 2D video system and 51 with 3D video system. Gender, age, BMI, tumor site, and post-operative stage were similar in the 2 groups. The operative time mean was slightly longer in 3D group, 168 compared to 158 minutes, even if patients in the 3D group had a slightly higher proportion of associated surgical procedures, including mainly cholecystectomy and ovariectomy, 39.2 compared to 30.4%. This difference was statistically not significant, and a slightly higher number of lymph nodes removed, 27.3 compared to 23.1. Again, difference statistically not significant. Multivariable analysis. On multivariable analysis, the adjusted mean difference, considering the effect of other variables in operative time between 2D and 3D video systems, was just 2.5 minutes. The only parameter which was significant of multivariable analysis and predicted a prolonged duration of the operation was the presence of an associated procedure. Multivariable analysis was performed also to evaluate the length of stay. Once again, the difference between 2D and 3D group was very small, less than 0.5 days in favor of 3D group. Patients, presence of morbidity and BMI were the only predictive factor of prolonged duration of the hospitalization for the patient. Overall morbidity was similar in the 2 groups, 32.1 in 2D compared to 25.5 in 3D. Again, difference statistically not significant. 4 patients required reoperation, 1 in 2D group due to abdominal collection, and 3 patients in 3D group, 2 patients due to bowel obstruction, 1 for adhesions and another 1 for internal hernia. The 3rd one was reoperated for massive bleeding. Multivariable analysis of morbidity. None of the parameters considered and listed in the table were predictive of, were significant, and they did not predict morbidity. This table summarizes the only available studies comparing laparoscopic right hemicolectomy with 2D and 3D vision system. As you can see, the 2 studies included 50 and 58 patients respectively. no significant difference between 2D and 3D groups in terms of operative time, morbidity, number of lymph nodes retrieved, blood loss, and length of stay. We come to the conclusions. Laparoscopic 3D video system is equally effective as 2D video system in laparoscopic right hemicolectomy with intracorporeal anastomosis. Actually, it allows a higher proportion of associated procedures and a higher number of lymph nodes removed. Clearly, further, hopefully large randomized and prospective studies are awaited in order to clearly assess if 3D vision system can reduce post-operative complications compared to 2D vision system, and if it can be helpful for novice surgeons. Thanks for your attention.